So welcome to the ICARE monthly webinars. I added AMLS to this because recently I became an AMLS instructor for NAMT, and it is a very good system that was very similar to what we're already running for ICARE, and it helped me enhance our own ICARE a bit. So this is also part of the advanced medical life support concept from NAEMT. So for the next hour, we'll have a chat about the ICARE AMLS scenario, the quorum way of doing things. So for those of you who don't know quorum or the college or know how we go about our CABCD EFGH patient assessment, this will be a primer. But for those of you who have heard this before, we will go deep into some fun things as well. So for the college, we start with big C, catastrophic hemorrhage, because that's what you'll die from first. After you sort that, you can move to airway and breathing and circulation. It's the same worldwide. Once we get down to D in disability, that could be fractures. It could be differential diagnosis. D is also for drugs. There's a lot of D. And then under E, environment and expose, we're covering the casualty if we haven't already. F, we're getting all of our vital signs. G, we're getting our ATMOS report ready to go. And H is prolonged casualty care, prolonged field care. And the reason I created this is because you have no choice but to automatically roll over to prolonged casualty care once you finish with your patient assessment. And what we found in austere environments that it is all primary prolonged care. So we definitely need to get into that. So let's start with a scenario. So you are working for the UN. You're a medic in northern Ghana. One of the local nationals working in the admin office is found lethargic and unwell, and one of your EMTs bring her into your clinic. So altered a bit. So at the college, we do our CABC just like everyone else. So we got catastrophic hemorrhage, airway, breathing, circulation, and I don't see anything big sick. So this is a medical problem, not a trauma problem. So I need to start getting my vital signs. And at the college, we have primary vital signs and secondary vital signs. The primary vital signs is CPRO. And the reason we do that is you can just whack on a pulse oximeter, and within seconds, you have a pretty good idea of the cardiovascular setup of your casualty. So capillary refill test on the sternum, pulse rate, respiratory rate, and oxygen saturation. So we're going to get these for this casualty. And we have 4 seconds of capillary refill. 115 is her pulse rate. Respiratory is 12, and her SpO2 is 92. So of these, we're looking for red flags. Are there any red flags in her CABC or CPRO? So we have a few. So we have she's cold and clammy. That's kind of shocking. I'm not really happy with that. This needs to be 2 seconds or less. Cap refill definitely needs to be faster than that. Pulse rate's a bit high as well. If she's not a pediatric patient, then 115 is an unhappy face, and I have a red flag. And then SpO2 as well for 92. It's just a whole bunch of red flags. So right away, we see this medical patient as a problem. So we'll continue on our CABC. We can get a disability check. She is A in the AVPU. She's alert and oriented ×2. Pupils are equal, round, reactive to light, and accommodating. And environment, she is in a warm clinic. So this is not an environmental problem. In northern and Ghana, it could be cold patient. Even though it's northern Ghana, it could be cold, could be warm. So we definitely need to keep an eye on that if we can. We haven't found anything quite yet. We're down to F, G, and H. And with medical patients, having vital signs is really good. It gives us an idea of our differential diagnosis. And we're still kind of stuck at the D in CABC-D because that's differential diagnosis. There's also diagnostic tests, but we'll get there. We'll get there. So we have our primary CPRO, and we already know that there's 3 red flags here. Now we have BEAST as our secondary vital signs. So BP is 105/52. She's sinus tachy on the ECG. She is ANO ×2, so she's altered a bit. Sugar is fine For you Americans, 5.9 would be about 90, I think. And temp. So that's kind of a red flag as well. I'm not too happy about that. She's uncomfortable. She's not necessarily in a lot of pain. She has just an uncomfortable feeling. 3 out of 10. We haven't got a lactate on her. Might want that. And ETCO2, we can do a blow by if we have a chance. But at the moment, we have a whole bunch of red flags. So 3 on our C Pro, we have BP is a bit low. I'm not too happy about that. She's altered. That's a red flag. Temperature, that's a red flag. On her pain score, it's a red flag. Now, since this is medical, and those of you who've come to Malta and done our ICARE, you know what's coming next. So, what's her map? I want all of you guys to put into the message her map, her mean arterial pressure, and you can use that by getting her BP. I'll wait. So, Andrew, you have 70. Anyone else? Scott, 70. Anyone else? Cole? Good. 70. Canadians are weighing in here. Good. So I'm happy with 70, kind of. Josh, you 70. Good. 70's okay. Now, I am not really having a happy face here because it's too close to 65. And anything down towards 65 or below, and we've got a really big problem. So her map is okay. Now, like anything that we do in austere medicine, from here, we trend. So now we have our baseline map of 70. And now we're going to trend to see if this is getting better. Scott, good. Shock index. So I didn't put that up here. So shock index is a really good indication. So shock index is going to be the ratio of my BP and my pulse. And as soon as my pulse rate gets above my BP, that's a problem. And what is the shock index? It's 1.1, isn't it? 1.2. Can somebody do the shock index for me? Who's got the shock index? Because when your pulse rate and your BP are equal, it's a 1. Good. Finn, brilliant. 1.1. We got 1.09. Well done, Dimitro. So you're right. Shock index is not happy. All right. So we have a problem with our map. Well, okay. We don't have a problem with our map. We're going to trend it from there. But shock index is not good. So that's a red flag. Cap refill is a red flag. Pulse rate's a red flag. SpO2 is a red flag. BP is a red flag. But the map, we'll see. We'll see where it goes. She's altered. Not happy with that. Temperature. I know we're in Ghana, northern Ghana. I've been there. It's hot. What, 39? Yeah, I'm not too happy about that. So we have some vital signs. And with that, we can then go back to our D and we can get a history of present illness and then we can get our differential diagnosis here in a second. So sampler. So at the college, we get an R in sampler. Don't forget the R. So what is she saying? I'm not feeling well and I feel like I will pass out. All right, that's definitely not good. We don't have allergies from her, past medical history from her, past any medicines. Somebody saw her eat breakfast of rice and beans, and she was filling out paperwork before this happened. And then the R. This is a big, big thing that we're looking for is recent travel. So she has never left this valley in northern Ghana ever. We're not quite getting an OPQRST on her. So we're getting some red flags, but this is differential diagnosis. So if you guys want to have a scan, this is the second time I've tried out the Mentimeter, and it's kind of great interaction. So if you scan that feller and you can start giving me differential diagnoses, and I think you can enter in as many as you want, but what does she have? We need 5 differential diagnoses. Heat related, good. I need 4 more. And this is altered and a high temperature. So you should probably have a lot more than 5. If the scan doesn't quite work, you can put it into the chat as well. I don't mind. Sepsis, good. Dehydration could be sepsis and dehydration. It could be hyponatremia. It could be if she has just been drinking water and not eating. Yeah, she could have a lack of salt. Sepsis, we got a couple people saying sepsis. We got a couple people saying malaria, endemic diseases. Yeah, yes, that's a safe guess. We have 2 people saying malaria. What else we have? A gastric disorder could be a GI issue. We have to ask if anyone else in this camp has had the same thing. So infection, definitely, because we have temperature, don't we? So we need to add all of these to our differential diagnoses. Say we have sepsis. So we have two with sepsis, two with dehydration, two with malaria, as well as one statement in the message board. Malaria, depending on season, it's always malaria, isn't it? Regardless of where you are, it's always malaria until proven otherwise. So you guys have five. We're going to go with sepsis, dehydration, malaria, and two more. Infection, general infection. I'm all right with that. Oh, envenomation. That's interesting. So we have some. D disability is also D differential diagnosis, and it's also D diagnostic tests. So let's see what I have. I put a bunch of stuff up here. Now we have our 5 or 8 diff diogs. Now, what kind of differential tests? So in the chat, I want you to type what diagnostic tests do you want to give this lady? And I'll wait. Malaria, malaria. Oh, urinalysis, Cole. Grand. That's excellent. Lactate, yeah. Venous blood gas, definitely want that as well. So we have 3 malarias wanting a rapid test on that, and a dipstick is always good. So let's do some tests. That's part of D disability. So we have a glucometer. So we have sugar. We can test for that. Sugar it was 5.9, wasn't it? Which is what, 9 or 10 for you. Sorry, 90 or 95 for you North Americans. So we need lactate. And you guys mentioned that for infection. We can also look at sepsis with your venous blood gas analysis for white blood count. If we had a microscope and some training, we could do a blood smear and get a CBC complete blood count of just the blood smear. So we don't necessarily need a ISTAT or an EPOC. But as a lazy medic, I would much rather have an EPOC than have to do a blood smear. So we also have some tests, and we have malaria tests, we have dengue tests, we look at trypanosomiasis. There's a whole bunch of stuff in northern Ghana that we can have. And the big one is the one that's going to kill people. So we are quickly going to look at the malaria RDT. We'll have a chat about that in a couple slides. We can do dengue if we want, even if she doesn't have the rash. If it's endemic, we can do that. Cole, you mentioned your analysis. I didn't put that up here. That's fantastic. Everyone gets it. Everyone gets your analysis just because we might be looking at a specific gravity that's off the charts, and it'd be a dehydration, but it could be malaria and dehydration, or it could be malaria and dengue and dehydration, or it could be 2 different malarias. People are cheeky. People can definitely give you things that are a curveball. Anyway, so here's a page from the field guide, 128, altered mental status. There's also the yellow section, which has the neuro exam, which we're currently revamping at the moment. We're adding a lot more of the medical, the AMLS section. We're actually calling it a medical section of the field guide. But so we had AIOU tips as a mnemonic for anyone's altered, and GCS. Now, I'm not a big fan of the GCS because what do we have? We have 20 people in the room at the moment, and we get 20 different answers on what the GCS is. So I'm a big fan of alert and oriented times 4. I'm a big fan of APU or ACPU. There's a new C and confused for alert, confused, verbal, pain, and unresponsive, which is fantastic. So we definitely need to monitor and trend this casualty's altered mental status. So let's get some test results. So our glucose was 5.9. Lactate came back as 1.1. Let's trend it, shall we? Because anything over 2 is a big red flag. But if it's 1.1 now and 1.6 in 20 minutes, that's also a red flag. So our venous blood gas is normal, which means the white blood cell is normal. So the malaria came back positive, dengue came back as negative, and trypanosomiasis came back as negative. So let's have a chat about malaria. And those of you who have heard me in class in Malta, you know I can't go very far without having a chat about malaria. So right here, this says PF, falciparum, Plasmodium falciparum. So that's the big one. That's the one that's going to kill you of the 4 that you have. But when I get my malaria test kits, I want more than just 2 options. One is C. And just like every rapid test we've had from COVID all over the place, we have our control line. Of course we do. Now here we have PF, falciparum. I don't like this one. I prefer to have PF and another one here that says PPAN, meaning falciparum, all of them. So you can use falciparum. This one it's only has a yes or a no answer, which is, in all fairness, it's fine because it's going to find the big killer. The problem is each one of these, depending on where they're made and who makes them, is about 95% success rate. Now the Pinax now is 99, and in all fairness, that's pretty good. But some of these are like 95% success rate, and I'm not willing to let 5% of my casualties die a horrible death just because I'm too lazy to carry two of these malaria kits. Now, I'm going to carry one and I'm going to look in the back. It says what is testing on this kit. And if I'm looking at an HRP2 enzyme on the protein molecule that tells me this is a falciparum, that's great. The next test has to look at the HDL, which is another part of the merozoite. So if you have two of these test kits looking for two different things on that merozoite of the malaria, then my chances of missing this malaria is very, very, very small. And look how tiny they are anyway. You can carry a whole bunch of these. So why not have one that looks at HRP2 and one that looks at the LDH, and make sure that you will definitely catch malaria or detect from. We don't want to catch malaria at all, but if we want to detect malaria, other test results we can do is, and those of you who know me, I can't go very long without talking about POCUS either. So this is the eye, and in the back of the eye we have cranial nerve 2, and any problem with ICP, this cranial nerve 2 will change size. It'll get bigger than 5. Anything over 5 is pathological. Anything up to 6 or 7, you can actually calculate the ICP from just how wide this cranial nerve 2, this optic nerve is too. But when it's from 5 mils to 6 mils, that's a pathology, but you can't quite measure the ICP. So we're going to trend everything, right? You should have the word trending tattooed somewhere because everything we do, we trend. And this is how we do it. We get the ultrasound probe and we put a whole bunch of ultrasound gel on the eye. And if you don't have sterile gel, then we want to put a sterile cling film, and all cling film sterile as it comes off the roll. So I put the cling film down, get all the air out of between the cling film and the eye. I put in about 20 grams of ultrasound gel. And then this feller here is using the linear probe, which is pretty good. I use my IQ butterflies, it works as well. And I'm going to get a really good view of the back of the eye. And we measure 3 mils down from the globe, the fluid of the eye. And then from there, we measure the optic nerve and we trend it. We trend it. So clinical exams. So this is a medical casualty. What clinical exam would you want to give this casualty? Yeah, what do you want to know clinically? And I know there's some docs in here that are going to be way better at this than I am. So, and some of you guys are advanced paramedics as well. So in this chat, tell me what clinical exam you would want on this patient. Oh, in the chat is a question from SS about fecal. Sure, you can do fecal tests because they might have some sort of parasite. So any of our fecal tinea or E. coli or Giardia, it's always good to test. And if those of you who've gone to the London School of Hygiene and Tropical Medicine or Liverpool and done their microscopy, we do lots of fecal as well. Good. Full blood count. That's not a bad idea to see if there's a shift in the white blood cells. Good. So we're still kind of stuck in D. And in medical cases, we are. So we're doing our differential diagnosis. We did our diagnostic tests and we did our clinical exams. Now we need a diagnosis. So we have a positive malaria test, but we have 5 differential diagnoses. We want to make sure that there isn't something else. So we did a dengue, that's out. Trypanosomiasis is out. Sepsis, we haven't rolled that out yet, have we? It's 1.1 on the lactate. Sugar's fine. Alcohol, yeah, we could have heat illness still, but let's focus on the big feller that might cause some death. That's always bad. So, what to look for in malaria? And this is something I came up with recently. It's just a mnemonic because I'm a knuckle dragger and I'm not that smart. I like to have things to help me remember. So I use jaundiced as a way to remember how to deal with malaria. Diana, you asked about skin and belly assessments. We haven't done that. We could do a belly assessment for ascariasis or something like that. You can see that with ultrasound, but there doesn't seem to be any GI issues at the moment. So a jaundiced is a way that I remember how to deal with the malaria. So the malaria patient will be jaundiced because of all the merozoites of the malaria in the liver that is just procreating. They'll be anemic because the merozoites are eating red blood cells, and therefore you're anemic, unable to swallow if you are severe malaria. So one nice thing to see the difference between severe malaria and mild and moderate malaria is whether they can swallow. And it's not definitive at all. So can they swallow? Doc Mason asked, is the jaundice from the malaria or from the hemolysis? That's a good question, Doc. The jaundice is from the liver's inability to clean the blood. So it's not necessarily the hemolysis of the blood cells because that's anemia, but the jaundice is because so much of the liver can't work anymore that it can't clean out, and that's why you get the jaundice. Just like all these other liver diseases that cause jaundice, such as cancer, it's the cancer is breaking down the liver's ability to clean, and therefore it's the same for the merozoites. The liver is just being eaten alive by malaria, and it doesn't have the ability to clean. So, and in jaundice, good question, Doc. Thanks for that. Keep them coming. Altered mental status because of that increased ICP. Their glucose is going to be way, way low, and we need to make sure that we keep that up. Increased ICP, and we're going to monitor that with the ultrasound. Could be some convulsions, what could be an indication of cerebral malaria. And once we have cerebral malaria, or they can't swallow, they are severe. And elevated lactate, so we got to keep an eye on that. It's 1.1 at the moment. And dark urine and diarrhea. So you have both of these under D. So prolific diarrhea and the urine is black because of all of the blood cells being eaten, but broken down. So the merozoites will just take over a blood cell, make a big merozoite factory, just destroy the hemoglobin and everything in it. And that byproduct is going to make the dark wee. Good. So I use jaundice to help me remember all of these things. Now there's a whole bunch of them. There's a big contention at the moment about maybe a sixth one. And in all fairness, the Noelzy is so tiny; it's just an offshoot. We're looking at the big four, and falciparum is the one that kills most. 620,000 deaths each year. There are 2 vaccines currently being worked in sub-Saharan Africa. We hope the best for them. Vivax is pretty important because that will hide in the liver and not do anything. It'll go to sleep. And then the whole body's like, oh, God, we don't have any Vivax at all anymore. And like months can go by, years could go by. And then suddenly the Vivax in the liver is like, you know what? I've had enough sleep. I'm going to just start making merozoites again and cause the whole problem all over again. So there's a special drug we have that can clean out the Vivax in the liver. The malaria IE and the Ovali are not as deadly by any means. And the Ovali and the Vivax are so similar that at London School, when we're doing microscopy, we usually call something Ovax because it looks so much like Vivax and so much like Ovali. We just call it Ovax until we find another, like the band form or something that we can see to differentiate that. So those are the types of malaria. It's a mosquito-borne infectious disease. It causes fever, tiredness, vomiting, headaches, and liver problems. Liver, yellow skin because of the liver. This is page 232 of our main field guide that Jason Jarvis put this together, and the types of malaria, the signs and symptoms of malaria, looking at fever, chills, rigors, anemia, cerebral signs and symptoms, and the treatment. So let's talk about the treatment. So the best treatment is to not get it at all. So I always take Malarone. I've tried Doxy, and being Irish in the sub-Saharan Africa with Doxy, it's not a good idea. But once you have malaria, you can take Coartem. So there's one that's a tablet. This is a tablet, and this is not. So if they can swallow, we're going to give them Coartem. So that's how we can differentiate between severe malaria and non-severe malaria. So if they have severe malaria, we're done with the tablets. We're going to give them injections. We're going to get the nuclear option. But as long as they can swallow, we can give them the Coartem. Good. It's caused by this feller right here, the Anopheles. This is a Aedes aegypti. That's a dengue. But this is the falciparum. And you can see that it when it bites, the bum goes up into the air. So that's one way you can kind of see that this is an Anopheles mosquito. And here you have some of the wee beasties, the merozoites, as they're floating around. One got into the blood vessel there, and it's going to make its we call them headphones. It kind of splits and makes two big dark things with a line in between, and then it just makes a whole bunch of merozoites that are little well, when I see this, I call it pizza because the red blood cell looks like a pizza and all the merozoites look like the salami sausages. So, and I always say that when I'm in London School of Hygiene and all the microscopists are not very happy with me. It's not pizza, but for me, it looks like pizza. So we give this lady Cortum because she can swallow. And we're going to refer her down. She's an 8-hour drive to CAF. And I've been to that hospital as well. It's gigantic in Kumasi, and she'll get definitive treatment for malaria. So when to evac? Signs of severe malaria, meaning can they swallow? If they can swallow, they may not have severe malaria. Doesn't mean they don't have. I mean, if somebody with severe malaria could swallow if they're motivated, right? But like every Marine could probably get severe malaria and they still swallow because they're Marines. But I'm looking for liver involvement, jaundice, any type of brain problems, any altered. So these are altered mental status is going to be indication for evac because we just don't want to risk this one. We don't want to play around with this one at all. PFC. Can't really have a chat without talking about PFC. So if you have severe malaria, you have a patient that has diarrhea, has got dark wee, you need to get their glucose up. Just think about all of the problems that this casualty is going to have whilst you're waiting for that helicopter or the truck to come to take this lady 8 hours down to CAF in Kumasi. So you're dealing with her. So she's defecating, she's peeing, her blood glucose levels is dropping, her lactate's going up, and is she hydrated? And she might be just normally dehydrated because this northern Ghana is really hot, and we need to maintain this person. So we use Pittman sheep vomit. So Pittman is a mnemonic that I first found when I was teaching battles with the UK and the SAS in Hereford. They came up with Hitman. They had a different H and they had a different N. So I nicked the Hitman and I changed the H to head to toe exam about 10 years ago and added nursing care. And then Jason Jarvis and I came up with sheep vomit. We may not have been sober, but it works. And now it's being used as a checklist for nursing care. Improvisation. So you have to improvise for this casualty. So you need to make sure that she's comfortable as part of sheep vomit, that she's elevated to 30 degrees because if she has severe malaria, she has ICP problems. So you need to elevate her head. How are you going to do that? Right here, we have a picture of her being on an EMS stretcher. She's not going to be on an EMS stretcher. She's going to be laying on your clinic bed that might not have a raised head ability. So you need to come up with some way to elevate the head. I'm a big fan of bin bags. So if you get a good solid, like a garden waste bin bag that's thick, you blow that up, you tie it off, and you stick it behind her. You can get her. Sometimes it's too much. You might need to put some air out of the bin bag because you need her right at 30 degrees. The science is saying 30 degrees, not 45, not 10, 30 degrees. So think about this casualty and what she is going to need in a prolonged environment and trending, right? Trending in vital signs and getting the ICP of measurement of her nerve sheath of the optic nerve and trend all of the vital signs. And if she's hot, we need a mist and fan to cool her down. If she's cold, we need to keep her warm. So this is not an easy patient. Meanwhile, we've got to make sure that her drug regimen is solid, that she's getting all the drugs that she needs to combat this. And do you convert into artesunate or do you keep her even if she can swallow? If she's getting worse and worse and worse, do you just pull the trigger and give her artesunate IV? Because why not? So there's a whole lot of things you can do with this casualty. So references, we use the field guide and Medscape. For any of you who don't know who Medscape is or what Medscape is, you're losing cool points. It is a free medical guide. It's an offline app, and I update every time I'm about ready to head out the door, and it works even if you don't have Wi-Fi, and it's free. And the docs in the room, I know you've got up to date on all these other things that cost $3,000. I work for a nonprofit and can't afford that. And to be honest, Medscape is just as good. I've used Up to Date. I've Medscape. So if you don't have it, and you are coming to Malta, you better have it by the time you get to Malta. So take home message. Jason Jarvis is correct. Any fever in the tropics is malaria until proven otherwise. But because this is an ICARE and AMLS scenario, medical, we also do R and sampler. So anyone who's traveled to the tropics has malaria until proven otherwise. And if they can swallow, they may not have severe malaria. If they can swallow, they still might have it if they're, well, I don't know how many Marines are in the room at the moment, but I want to get out to you guys. You guys are pretty hard charging. Doc Mason, you got a question? Can we make the field guide into a proper app on the Play Store? Yes, we're working on that. I was trying to get, so we're using Codeby as our hosting of all 4 field guides, and you can get them on our website and have access by the desktop. And then I tried for 3 weeks, and I failed miserably trying to get the app. So there's a Codeby app, but then we have to convert. Anyway, I'm a really crappy IT guy, so I handed over to somebody in the college who is an IT guy. Phil is an IT guy, and hopefully we'll have it within a fortnight or so. So yes, Doc, yes, we will have the ability to download the Codemy app, which you can do now, but then we're trying to connect the app to our Codemy account, which is, yeah, Phil Clark is smarter than me, so I'm sure he'll get it up and running. Good. For those of you who haven't been to Malta, you can scan this or just go to our website if you want a 5-day course in ICARE, and we always run AMLS and PHTLS after. And now that we're running AMLS and PHTLS, and for those of you who have not heard of that, I know there's quite a few who are graduates as well as currently enrolled in our master's program. This is a good idea. So this is our second month. I saw the student reviews from ICARE saying that they wanted this. They wanted a monthly seminar, and we put this together.